Good morning, sir.
Thank you. Good to be here.
Morning, doctor. How are you?
I'm good.
Wonderful.
Great to meet
Okay.
you.
Nice to see a lot
Likewise,
of
sir.
literature behind you.
Yeah, in fact, you know what? I saw one of your podcasts, Dr. Stephen, and in that podcast, the author, I think the someone who was conducting it, she asked you to pick a book right from your shelf. Yeah. And then I think I didn't get into the discussion after that, but then yeah, I mean that's how it began.
Oh, that's wonderful. Thank you. As a matter of fact, I do want to make sure, as part of this, I'm going to send you a digital copy of the book that I wrote, um,
Mhm.
which a lot of the principles of what we're doing at UNIFI are actually based in that book that I wrote back in 2001.
Oh,
Okay.
oh,
All right. Got it.
that's great.
Got it, sir.
Yeah.
Uh,
So you have it in the digital format as well, available,
Yes,
which can be shared. Oh, wonderful. Yeah. I'd like to read that.
okay. Shall we begin now?
absolutely.
Yeah. So, yeah. So, as in business, so in lives, healthcare has triggered staggering fundamental changes, impacting our lives and surroundings like never before. There are millions who are reaping a very rich harvest of opportunities, and then there are bystanders, many a times more, watching in amazement, unaware of the long sweep of this emerging field. Good morning, everyone. I, along with my colleague Yuvraj Sani from Hospital and Healthcare Management, welcome you for this session. It is indeed a great pleasure to have amongst us Dr. Stephen Merahn. A fellow of the American Academy of Pediatrics, Dr. Stephen Merahn attended the Albert Einstein College of Medicine in the Bronx and finished his pediatric training at the Bronx Municipal Hospital Center at Montefiore Medical Center. Besides being an expert on autism, he is currently serving as the advisor to UNIFI Autism Care. We feel privileged to have you on board, Sam, and thank you so much for your time.
Thank you.
And to begin with, we're really keen to know about the existing autism diagnosis in the US.
So, you know, the American Psychiatric Association has a set of criteria that is variously published in something called the Diagnostic and Statistical Manual. It's currently the fifth version of that manual. Over years, the diagnostic criteria for autism has changed. With the last version of the DSM-5, they took a number of diagnoses that were peripheral or related to the autism diagnosis and combined them all together into a single diagnosis that they called autism spectrum disorder. And they did this because they realized that so much of the characteristics of other conditions, pervasive developmental disorder, what was called Asperger's syndrome, all were part of this overall syndrome because autism expresses itself, the phenotype, the way it expresses itself in the world, is very variable. And there is a tremendous spectrum that are grounded in a set of diagnostic criteria. Those criteria include three things. Number one, it has to present and begin in childhood. That's a foundational element. But the two core criteria are persistent deficits in social communication, relationships, and interactions. That's one big criteria. And the other is restrictive or repetitive patterns of behavior, interests, or activities. Now, again, this is extremely variable. It could be as simple as I love trains, or at the other end, it could be very disruptive patterns of self-injury. So again, the spectrum of that particular behavioral criteria is very, very wide. However, over the years, it's been very clear that there are other conditions associated with autistic individuals that seem to be common patterns of reoccurrence. And those are variously called co-occurring conditions. Now, they're not part of the autism diagnosis, but once someone is diagnosed with autism, these conditions are extremely common in that population. So seizures, sleep disorders, sensory deficits, gastrointestinal conditions, metabolic problems, hormone problems, as well as kind of peripheral or related mental health conditions like attention deficit disorder. Again, those are not part of the diagnostic criteria, but they are part of what we would now continue to call the autism spectrum. And what I'm hoping we can talk a little bit about today is some of the latest evidence in the genomic realm that actually supports the idea that autism is far more than just a neuropsychological condition. It's not just, there's not just an autistic brain, but there's an autistic person. And the more we can look at the autistic person as an entity, the more we can realize that in many ways, autism is not necessarily a disability, but there are autism related disabilities that, because of this spectrum, because of the diversity of what autism can be in a population, we need to begin to consider that in our treatment. And one of the things that we're doing really differently at UNIFI is, instead of just treating the diagnosis related symptoms of behavior, the behavioral stuff, the neuropsychological side, we're also looking at how some of these co-occurring conditions can actually benefit from behavioral intervention. It's been well established that most of health outcomes, and there's articles in the New England Journal of Medicine, and the US federal government put out Healthy People 2030, that the vast majority of outcomes really is dependent on behavior and environment, and really only 10 to 20% is responsive to medical care. So we want to expand our view of the support we can provide the autistic community by not just focusing on the diagnosis, but focusing on the whole person.
Great. Okay. Got it. So what are the treatments that are available in the US as of now? I mean, when you talk about the discovery of the behavioral patterns, what are the treatments that we can, expect in the US as of now, at present?
Well, the anchor, the therapeutic anchor for most people with autism is a form of therapy based on the principles of behavior analysis, variously called applied behavior analysis or ABA. I've dug into this a little bit deeply. I'm fairly deeply involved in the behavior analytic community. I've come to understand the science of behavior analysis actually has applications outside of autism. But over the last 20 years in the States, every state of the union has passed legislative reform mandating access to therapy based on behavior analysis for children with autism. Now, that started slow, I'll tell you, in 2000, 2001, it was a handful of states. And over the years, it's grown to the point where I think the last state was just 2 or 3 years ago that, again, mandated insurance companies and other payers to pay for access to this therapy. There are other forms of therapy that are important for children with autism. My behavior analytic colleagues might not be happy with me saying that, because they really believe that their therapy is, in fact, when applied properly, when applied with a level of developmentally appropriate practice, when applied in a naturalistic developmental sense, really is the optimal intervention. But the fact of the matter is, as we look at, again, autism as a whole person condition, we have to acknowledge that there's other ways that children with autism can get the support they need, even ranging from psychotherapy. I mean, just, the kind of thing that we may have for our own, mental health can really benefit children with autism. Speech therapy, occupational therapy, medical care, obviously. But the anchor for getting children the best outcomes really is grounded in a very carefully crafted behavior analytic treatment plan.
Okay, great.
So if we have to ask you, doctor, I'm so sorry, Susan. If we have to ask you, doctor, is there a particular time frame or an age limit, or do you think this should start? When a lot of people have this question, like, when should we start the medical treatment
Yeah.
from? When should
Great question. Well, I mean, the good news is the studies are very clear that the earlier you intervene, the better the life course outcome for a child. That there's no doubt about that. The problem is that there's a lot of delay in getting the diagnosis. So if you start a child at age 2 or 3 or 4, the chances of them going into the school system requiring less, I'm not saying no, but less services and supports is very, very high. It also, by the way, stabilizes the family, relationships with siblings, ability to live in the community. I mean, there's all sorts of benefits of early intervention. However, having said that, I work right now with an adult population with autism. I'm the medical director for a small organization in New York State that cares for adults with intellectual and developmental disabilities, many of whom have autism as their primary diagnosis. And it is very clear to me that there are applications of behavior analysis that can significantly benefit adults. It's a different, you're treating something different. You're not necessarily doing you're not in with young children, we're really focused on supporting their developmental trajectory. In what ways might autism, or might in what ways might their autistic symptoms and behavior be a barrier to developmental progress? We want to remove the barrier and then support their strengths development. That's what we do for childhood. In the teen years, for example, there's a big challenge for autistic children when they make the transition from elementary school to what we call in the States middle school or junior high. And it's around the early teenage years, 12, 13, 14. Tremendous social challenges during that time. Autistic children who may be very, very stable in the elementary school realm, where it's the same class, the same teacher, it's a relatively controlled and consistent environment. All of a sudden, you're now in an environment where you're changing classes and there's different friend groups. The social challenges are different. So we want to intervene there around social skills. And then as people make the transition to adulthood, we want them to have as independent a life as possible. Now, there is a subset of children who have what is variously referred to as profound autism. They may be nonverbal. They may have severe challenging behaviors. Even in those children, there's a significant opportunity to, again, reduce the behaviors that are challenging in order to give them the maximum opportunity to interact and have positive interactions in the world. So again, as a pediatrician, remember, I'm not a behavior analyst. I have no reason to promote this therapy except that I've looked at the science. I really do believe that there's a benefit in some way for people to receive behavior analysis when there are behaviors that are interfering or behaviors that can benefit from their health-related behaviors, their again, mental health conditions, their interactions with the environment.
So, if I have to say so, when we talk about behavioral therapy, as you said, that each child can behave differently in different phases of life. So then, in that case, I would probably assume that behavioral therapy is a lifelong process, because it can be required in any phase of his life wherein there is an environment change happening over
I could use some right now to remember to take my blood pressure medicine.
there.
So
But
yes,
Samit,
you're absolutely right.
Yeah. Okay. Yeah,
so
Shashank.
yeah. So what I want to say, I mean, because is it too little, too late, Dr. Merahn? Because we've been having these conditions, we've been seeing people suffering from this condition since a long time. But then what we are observing now is suddenly there is a big surge in the kind of treatments that are going on. So, but is it too little, too late?
I don't think so. I think one of the things that's happened over the years is that we've gotten better at understanding the specifics of people's conditions. For a very long time, we kind of lumped everybody together under this umbrella of intellectual and developmental disability. You have a problem in childhood, whether it's learning disabilities or challenging behavior or oppositional, whatever the challenges happen to be, everybody got lumped into this single diagnosis. And over the years, we've got better at parsing out the specific person-centered characteristics that have allowed us to really develop better person-centered therapies. I think that there is absolutely a population of both older children and adults who may not have gotten the therapy early in life, but that doesn't mean that they don't deserve an opportunity for therapeutic intervention later in life.
Absolutely, sir. Yeah. So I get on to my next question, which is how does Unify Autism Care offer therapy for a whole person condition standpoint? How does it do that?
Yeah. So one of the things that we've done, and again, Unify is unique in that there are very few, and I mean handfuls, of the thousands of behavior services providers in the States who have a pediatrician that's part of the team. Um, I will say I'm grateful to my behavior analytic colleagues for allowing me to embracing my perspective on children, because healthcare, unfortunately, as you alluded to before, is sometimes very siloed. Disciplinary silos are drive a lot of what happens in healthcare. So
Correct.
what we're doing is we're saying, okay, the child may have, again, diagnosis related symptoms of behavior that need intervention. But if the child has epilepsy and there's a problem with them taking their seizure medicine, we want to address that issue as well. Children with autism use the emergency room 4 times more than non-autistic children. They're admitted to the hospital more frequently. And many of those are preventable. And they're preventable through behavioral interventions, because it is, in fact, behavioral. There's foundations of behavior in the reason. So again, if you don't take your medicine, you're gonna break through in whatever the condition is, whether it's asthma or seizures. Children with autistic children often have gastrointestinal problems or sleep disorders that can be very disruptive to their own well-being, but also the well-being of their family. So we're not restricting our perspective on that child just to the autistic related symptoms and behavior. We're taking a much broader perspective on that child, and our view of outcomes is less about their response to treatment in any given treatment cycle, but really about how what we're doing today can affect their life course trajectory into adulthood. Because we know that autism doesn't go away at age 21, even though in many states right now, the access to behavior analytic therapy ends at age 21, that adults don't necessarily have the same access that children do. But our focus is, where is this child going in adulthood? How independent? How much, by the way, can we make them comfortable with themselves? That I say often that an autistic person's perspective on the world is normative for them, and we have to stop trying to shape behavior to meet some external perspective of what normative is, because we want people to be comfortable with themselves and make a contribution to the world. There's a great quote from Temple Grandin, who's a very famous autistic author and speaker, and she says something like, "If we took all the autistics out of the world, you'd have a bunch of people standing around talking to each other, but nothing would get done." So there's a real sense of the contribution that the autistic perspective can make to society and community, and we want to keep that perspective alive. In many ways, it's a unique perspective that can make a contribution, because they might look at the world a little differently than other people do. As, by the way, in my perspective, we all do to a certain extent.
Yeah,
Absolutely. So, I mean,
that's a great observation. But then, if I have to add, when we talk about an autistic child, let's say we discussed about an autistic child or an autistic adult, it's not the child which is only, or the world is changing only for him, but it's the entire family, or it's the entire people who are associated with his well-being are also getting affected. So if I have to ask, how do Unify emphasizes on creating an integrated approach
So
towards the autism care.
again,
Yeah.
part of our view of the child is the environment in which they live, because you're interacting with the environment. So we actually have a commitment to doing tremendous family involvement in our therapeutic process. Families are actually engaged in the therapeutic process, so that the child isn't just in therapy when they're with one of our behavior analysts. The therapeutic techniques can be applied in the family even when we're not there. So we do it. You can call it parent training, but it's really family involvement. We look at family interactions significantly. We look at siblings. Siblings play a really important role, both in terms of the effect of having an autistic sibling on that person's own development, the effect of an autistic sibling on the way their parents interact with them. And we try to neutralize the disability component of this and help people accept and commit to who their family members are. I have 2 children. They're very different people. They view the world differently. They're not autistic, but in fact, the fact of the matter is there's often interesting perspectives. And
correct.
having an autistic, if you look at your autistic sibling from that perspective, it really does allow you to accept, again, this is the norm for our family, and then you can move forward from that. So there is a tremendous aspect, and in some ways, families are not always, they think, oh, I'm going to my therapist, and that the therapist does the work. But in this particular case, it's really the therapist supports the family doing some of that work.
Yeah. So if I have to say, then probably shared care is the best thing to do over here, whether it's an
You you
autistic child or a non-autistic child. Yeah,
you
it's
you
it
you
it
you
has
you
to be.
you just spoke one of our mantras.
Well, so in that case, if I have to ask you, well, when we speak about shared care, we also have to educate the society. We also have to educate ourselves, our surroundings, and starting from the valet parking person in the hospital to the doctor to the nurses, everyone has to be
Yes.
trained on how to be taken care of. So, what is the long-term outcome you see, happening in the autistic world? Is I would say the change of the world is very much needed. The approach change is very much needed.
There's a quote that I love, and I wish I knew who said this, which is, we have to stop training autistic children to accommodate the world around them, and we have to start to train the world around them to accommodate the autistic child. And this, by the way, is
Definitely.
true across many forms of what are variously forms of disability, whether it's physical disability, intellectual disability, autism, others. Um, you know, uh, Accommodating differences, accommodating what is normative for someone else. I mean, this is the way to think about it. It's like there's no normal. What there's normative for me, and there's normative for you, and there's normative for this person. And if we respect what's normative for that person, then we're going to treat them and interact with them based on a level of respect. And there's certain expectations. I mean, even by the way, in the healthcare system, we're not always good at accommodating those differences when people come in. We build systems of care that are based upon common patterns because we build them around efficiency. We build them around the needs of the system as opposed to the needs of the person. And part of what we're trying to do at UNIFI is flip that around, is really kind of work on helping people, number one, have the best helping children have the best developmental experience possible, helping them, be able to participate as both emotionally, socially, economically as they get older in terms of their participation in the workforce as much as is possible for them, right? Not some expectation that other people put on them, but what they're going to be comfortable and happy and get joy out of in their life. But not necessarily impose something small on them because we've lessened who they are. That's where as a system we fail. But the fact of the matter is, there's system level changes and there's local changes. And as much as I've tried over the years to affect system level changes, what I've discovered is I can be most effective at the local level, which is why we're really focusing on this at UNIFI to try to create a different model, set some different expectations for how systems interact. Now, you talk about shared care. One of our critical approaches is actually partnering with some of those other members of a child's health resource community. So again, you've got an autistic child. They have a primary care, a child health professional, maybe a physician, maybe a nurse practitioner. They probably have a neurologist. They probably have a gastroenterologist. They have lots of specialists involved. There's a school system involved. There's others. And we're really trying to break down some of those silos. And because a lot of those systems are self-protective, but rather than us coming in and saying, you're doing it wrong or you should do it differently, our approach is, how can we behaviorally help you achieve your goals? How can we help the school system achieve its goals? How can we help, again, the family achieve its goals? One of the things that I remember in the earliest stages of me working with the autistic community, I asked a family member, I asked a mom, well, what are your goals for therapy for your child? And she responded by saying, I just want to go shopping and not have to worry about my child running away from me.
Well,
So that goal, by the way, is not in anybody's treatment plan. So what we did was we took that goal and we said, okay, let's unpack that. What do we have to do to make that happen? And we looked at the little individual pieces that are required. Step one, your child needs to respond to their name. That's step one. So let's make that a goal. Let's make that a goal. so that when you call their name, they respond to you. They turn to you and they actually understand that they've been called and they stop. That's goal number one. So we were able to take these little tiny goals and ladder them all together in order to achieve the mother's goal, which is I just want to be able to go shopping and not have to, because one of the problems was, again, there was a sibling. So every time the autistic child had one of their behavioral issues in the supermarket, the sibling was ignored. She just wanted to have a little bit of balance in her family. So we use that goal as the basis of the treatment plan. The more we do work like that, the more we go to the primary care physician and say things like, what are some of the challenges you're facing taking care of this child? And getting response like, well, I've never been able to draw blood because they have anxiety over blood drawing, so we can't, or they haven't had a dental visit in 2 years because they can't sit in the chair and they're terrified, when the dentist hangs over them. Well, guess what? We can do behavioral desensitization over time to get them more comfortable in the dental chair and get them the care they need. And that's really our definition of shared care at this point.
Mhm. I believe that's what makes UNIFI different from other care approaches.
We're counting on it.
So there's a lot of research that is going on. I mean, I'm sure that because of the fact that there is so much advancement that has already taken place. What are the current researches that Unified is, into, and what are the outcomes? If you can share that, please.
So there's two things we're working on, and we're not ready on the outcome side. Come back in a couple of months. We have some, but we have a very again, because of my child health perspective and the behavior analytic perspective, the way we collect data is a little bit different. So we're actually looking at health related social determinants, which can have a behavioral component. We're looking at medication management. We're looking at we're actually tracking chronic illnesses. We're asking some of our health, the payers that pay for services, we're asking them to share with us data on utilization patterns for healthcare, how many specialists they go to, how many times they've been to the emergency room, how many times they've been hospitalized. And we really want to be able to have an influence on some of that. That's where, again, in the States, what we call value-based care is coming in. The other side, and I just want to talk about this for briefly, is there's a tremendous amount of genomic research going on in children with autism. And it actually reinforces this view of the autism as a whole child condition. There's about 100 genes that have been identified and associated with the autistic community. The problem is there's no single pattern among them. I mean, basically, if there are patterns, it's around one. The patterns only show up in 1%. So it's so diverse, and some of the genomic clusters show disconnection between the diagnostic symptoms. So there's a set of genes that are associated with the repetitive behavior patterns. There's a set of genes that are associated with social communication problems. And the way they're mixed and matched actually reflects, we think, some of what we're seeing in terms of the idea of this as a spectrum. Now, is there therapy in that yet? No. But what it says to us at UNIFI is we're on the right track in terms of looking at the really doing person-centered, child-centered planning, because each child really is, in many ways, genetically unique. And therefore, their symptoms and behavior and autism-related co-occurring conditions will be unique.
But in that case, doctor, many a times we have heard a lot of parents saying that we have observed a tremendous change in the child, and they think that when they thought that the child is moving towards the right direction, suddenly there is a behavioral change, and then again it's back to zero.
Well, all right. So I'll tell you a story, and this is not related to autism, but children with autism still have many of the typical developmental challenges that go through. So, I don't know whether any of you have children, but I've raised 4. And there's very almost predictable changes that occur at various developmental phases. And whether you're an autistic child or a non-autistic child, those things are going to happen. There's changes in behavior. There's changes in responsiveness. There's changes related to puberty. These changes occur all the time. So I understand for many families of an autistic child, stability becomes critically important, but you can't discount the fact that these children are still going through what are in many ways normative developmental changes, which will change the way they respond to things, their sensory issues, their their own patterns of communication, and a lot of times that happens. Now, with behavior analysis, I will say sometimes there's patterns of behavior that have come up through families that they've chosen to do in order to maintain a level of stability. Sometimes we have to undo some of those because they're not necessarily they're designed to help the family be stable, but they're not necessarily right for the child's developmental progress. So if you're constantly, for example, if a child has severe food preferences and you're always going with their food preferences, which, by the way, not a bad thing to do, but in some cases, if you overdo it, then you never have the opportunity to introduce new things, the level of variation into their lives. So sometimes we have to pull away some of those things that families have done for stability, and there's often a response to that looks like things are getting worse, but they're not really, because we're gonna ride that wave into another opportunity for that child.
It's a very nice insight, doctor. Thank you for that. Yeah.
I would like to ask, sir, what are the actions that the managers and the healthcare community as a whole need to take so as to, better coordinate this entire gamut of autism care?
So we're working with a number of health systems that are looking to us for advice and counsel on how to handle, like you mentioned, the valet parking and the front desk, and uh, you know, there's not a lot of training on this that's available. I mean, even in medical school, uh, the idea of neurodiversity, which is really what we're talking about here to some extent. There's the full spectrum neurodiversity, and then as you move down the spectrum, it gets into the autistic spectrum. But the fact is, the neurodiversity spectrum is a lot wider, and
Right.
there are a number of health systems that have asked us, based upon the expertise and experience, not necessarily mine as much as the other behavior analysts that I work with, um, to how can they begin to modify their systems and processes so that when someone does come up who is neurodiverse, who may communicate differently, who may respond to things differently, who may have different sensory issues, how can they adjust and accommodate? And that's really the word that's used in the disability community. How can they, make the appropriate accommodations so that so that they are adapting to the person's needs, which to me is what healthcare should be overall. Um, uh, but again, this is you're asking that at a system level, and we're hoping that we can have some really nice demonstrations in smaller environments with some of the partners that have signed up early to work with us, so that eventually this can become a standard.
Great. So there's already a sense of benchmark that you have in mind and that
Oh
want
yeah. Yes, I do. Yes, I do.
to.
I think that I think personally that healthcare and our capacity to support people's quality of health is truly a social imperative. I think that when there's any kind of debate over people, whether people should be sick or well, for example, whether people should have a burden of illness or we can lift some of that burden of illness. That's really a social imperative, and it's a very human endeavor. And as much as I have, we talk about technology and technology supported care. I think fundamentally this is a human endeavor, and we can use technology to support our efforts, to enable our efforts, but this has to happen at the people level. That's my benchmark. There is to really humanize the systems of care.
Great, sir. And so with the kind of
That's going to
development,
help a lot in the long run.
yeah, and so with the kind of developments that are taking place when we talk about autism in particular, and when we see you talk about it, our faith in the entire system becomes much more stronger,
Oh, thank
Dr.
you.
Merahn. And surely does, because this session has been so interactive. It has been so, we've been very intrigued with the kind of developments that have been taking place as far as this uh, not so talked about issue is concerned, because as a matter of fact, this should have been given a lot of priority, right, probably a decade back, probably. I mean, the kind of work that we are doing, it should have been done before, but since it has already been taken up, and the kind of work that you've been doing on that, it really enforces our belief that yes, there is something which is really big coming up.
I I I'm touched by that, and thank you. I really appreciate the endorsement and the encouragement because um, it is mission based for sure.
Yeah,
Absolutely.
because at the end of the day, we want people and we want companies which are there not to just make the system, but to change the system. And people like you and companies like UNIFI is one of the example wherein the impact which you will create in the society will not be just for your sake or just for one community, but it is something which will be taken into consideration, and the whole world is a place which will enjoy the benefit of it at the
Well,
end of the day.
there's an analogy here to ecological science, and the science of ecology is very clear that the most diverse communities are the most stable. And I'm talking about from a species perspective. I'm talking about forests and ocean ecosystems. The most diverse species systems are the most stable, and the degree to which we can increase the level of diversity of of thought, of ideas, of behavior into our social systems, I ultimately really believe that there's an ecological benefit for that.
Well, that's a real pleasure to know you, Doctor. And we will definitely be waiting for your book now that we have spoken about this in detail. My thirst for reading your material is even more now.
All right. Well, again, thank you both. I really appreciate the opportunity to talk today. I'll make sure the book gets to you today, and feel free to circle back anytime.
Thank you so
Thank
much.
you.
Thank you
Thank
so
you.
much,
Thank you so
Doctor,
much
for
for
taking your
this,
time out.
this very enriching experience, Dr. Merahn. Thanks a lot.
Anytime.